Welcome to my channel once again, and today we are going to look at electrolyte imbalance part 1, and this is going to be based on hypernatremia and hyponatremia, but this presentation is specifically for hyponatremia. So let's begin. So what's electrolyte imbalance? So this occurs when certain mineral levels in blood gets too high or too low beyond or below their respective normal range of measurement. So let's take our first electrolyte. So we have sodium, which is a cation. So the normal level of sodium is 135 to 145 milliequivalent per liter in blood. So the normal function of sodium is to regulate fluid balance and osmolarity, maintain blood pressure, ensure for nerve impulse transmission, and then support muscle contraction. So at any point in time, there should be a shift in the normal ranges, whether more than or less than. This normal function of sodium will be compromised. So let's proceed. So we have hyponatremia. So that's low level of sodium in blood. So how does this occur? It occurs when sodium in blood is low compared to the normal ranges. This happens because when there is too much water and that water dilutes the sodium in blood, or because the body loses too much sodium, giving you a value of less than 135 milliequivalent per liter. So now let's look at the forms in which hyponatremia can occur. So we have the dilutional hyponatremia, it being the first one. So which occurs as a result of excess IV fluids. So when a lot of IV fluids are given, it goes into dilute the amount of sodium. That's why the name is dilutional hyponatremia. So we have SIADH, which is syndrome of inappropriate antidiuretic hormone secretion. So antidiuretic hormones are secreted to make the kidney tubules permeable and allow reabsorption of water back into blood in order to maintain fluid volume level. But in a condition where these hormones are oversecreted abnormally, will lead to absorption of more water into blood uncontrollably, leading to dilution of the sodium level in blood, which will lead to hyponatremia. So we have heart, kidney, and liver failure. All these conditions will lead to fluid retention, and that will dilute the amount of sodium in blood. As well as we have oxytocin use, which also increase water retention. Good. So now let's look at some of the few signs and symptoms of dilutional hyponatremia. So you can have confusion, where brain cells swells due to low sodium, so fluid will rush into brain cells. Then we have nausea and vomiting due to electrolyte imbalances. Then we have weight gain and edema because of fluid excess. Then we have muscle spasm and seizures due to sodium's level or ability to help in nerve conduction, meaning when there's low sodium over there, there will be malconduction of electrons or malconduction of electrical movements or nerve conduction, which will lead to muscle spasm and seizures. So let's look at how we care for patients under this form of hyponatremia. First, identify patient at risk, that's assessment as a baseline. We monitor for fluid intake and output as well as a baseline. Then we assess neurological status because we learned there will be confusion. So assessment is also needed. Then you have to restrict fluid if dilutional because there's more fluid in there. More fluid added again will dilute the sodium at hand. You administer prescribed medication and monitor for complications. Then you monitor for serum sodium. And then there's possibility where you have to treat for conditions that led to this situation like heart failure, kidney failure as well. So treatment to be done on those conditions. When those things are settled, it solves the problem. So we have a mnemonic here called RIM, where you are supposed to restrict fluids, monitor for intake and output, then mental status assessment, as well as administering prescribed medication, and then we monitor for serum sodium. So let's look at the second form in which hyponatremia can occur. We have the true hyponatremia. The other one was dilutional, meaning at that point there is more water in there and diluting the sodium. But here is true hyponatremia, meaning you are losing sodium, which will lead to less sodium in blood. So the causes are vomiting and diarrhea, which will lead to loss of sodium in the body, excess sweating. Then we have diuretics, drugs that will promote frequent urination and then excretion of sodium as in electrolyte as well. We have burns, which leading to a sodium loss due to damaged skin. Then we have adrenal insufficiency, which will now affect poor sodium regulation. So let's look at some signs and symptoms as well and why they happen. So you have low blood pressure because of a low fluid volume. Then we have fast pulse because the body will try to compensate for the low blood pressure. Dry mouth because of the dehydration, there's loss of fluid as well as water. But wherever sodium goes, water follows mostly. Then we have weight loss and low urine output because you lose a lot of water, so the body try to compensate for the water loss, so will reduce the amount of urine produced. You have muscle weakness, which is impaired muscle contraction, because we know that sodium also play a role in nerve conduction, which help in muscle contraction as well. So you have nursing care for the true hyponatremia. So you administer prescribed isotonic IV fluids as well as you monitor for hypervolemia because adding more fluids in there will now lead to increased pressure. So you have to monitor for hypervolemia as well. Medicate patients on proper intake of sodium and fluids. We have a mnemonic aim, which means we add sodium because the patient is actually losing sodium. So a true hyponatremia has to do with sodium being lost, while the dilution have to deal with sodium being available but it's being diluted with a lot of fluids. So the mnemonic goes as in. So we add sodium, we instruct patients on how to take sodium in diet and fluid. Then we monitor for volume status for potential hypervolemia. So thank you for your time and we'll meet next time in the next presentation on hypernatremia.